Good evening, and thank you all for joining us for this webinar, which is the last of a series of 4 which have been delivered on the subject of co-occurring mental health and substance use disorders, funded by the Central and Eastern Sydney Primary Health Network. My name is Catherine Mills. I'm an Associate Professor and Director of Treatment Research at the Centre of Research Excellence in Mental Health and Substance Use, which is at the University of New South Wales. And I have the pleasure of facilitating this webinar, which will be presented by Dr. Christina Morell. I'd like to begin by acknowledging the Bidjigal and Gadigal people, who are the traditional owners of this land, and pay our respects to elders past and present, and also to extend that respect to any Aboriginal, and Torres Strait Islander peoples who may be with us here this evening as well. So as I mentioned, this is the 4th of a series of 3 webinars. The first webinar was a very broad overview of co-occurring substance use and mental health conditions. The second focused a bit more on how you identify co-occurring mental health conditions among people with substance use disorders. Then the third looked at management and treatment of co-occurring conditions. And now this 4th and final webinar will provide an overview of managing physical health of people with co-occurring mental health and substance use disorders. And those 3 webinars that have already been conducted, you can access those from the CREM's website, which is comorbidity.edu.au. And on that site, you'll also find links to other webinars that have been conducted on substance use and mental health, their prevention and treatment, which are not only for clinicians, but also for people in the community, parents and teachers as well. And just before we start, I just wanted to draw your attention to the Q&A button, which is on your screen. Please feel free to ask any questions or make any comments throughout Christina's presentation. At the end of the presentation, we'll have about 10 to 15 minutes of discussion time where we can go through some of those. If you experience any technical difficulties, you can call the technical support number, which is on your screen, with the details there, or alternatively, go to the Zoom support webpage with the link up on the slide there. I'll also put this information into the chat box on your screen so that you can access that at any time during the webinar as well if you need to. And just lastly, like the other webinars, we are recording this one, and later on tonight you'll be able to download that recording and the handouts as well from the website on your screen. So it's my pleasure to introduce Dr. Christina Morell, who is a research fellow at the Centre of Research Excellence in Mental Health and Substance Use. And her research aims to improve our understanding of co-occurring mental and substance use disorders, and as well as improving our treatment responses, particularly among populations that have multiple and complex needs and often require a range of services. Christina's work is built on very strong collaborations with clinicians, consumers and carers and other key stakeholders. And a very big part of her work is also focused on translating research findings into evidence-based resources for clinicians and the general community. So thanks very much, Chris.
Thanks, Kath, and thanks so much for joining us for this webinar today. So as Kath said, the focus on today's webinar is on managing the physical health of people with co-occurring mental and substance use disorders. So although, as Kath mentioned, the webinar tonight is the final in a series of 4 webinars on addressing co-occurring substance use and mental disorders, you don't need to have attended all 4. Our intention is really to provide enough information that each of these can stand alone. So if you're interested in just knowing more about managing the physical health of people with comorbidity, for example, you can just come along to tonight's webinar. So there will be a bit of overlap between topics. And as with the first webinar that we presented several weeks ago, a lot of the material I'll be talking about tonight will be directly drawing on the 2nd edition of the National Comorbidity Guidelines, which are more formally known as the Guidelines on the Management of Co-occurring Alcohol and Other Drug and Mental Health Conditions in Alcohol and Other Drug Treatment Settings. And if you're interested in finding out more about this resource, it can be accessed here. And if you're worried you can't click on these links during the live recording, don't worry. I'll make this presentation available to download as a handout at the end of the webinar. So all of these links that I'll refer to throughout the talk tonight will be made live or available to be clicked. So before we get started, I just wanted to run through the learning outcomes of the webinar. And these are to have an improved understanding of the behavioural risk factors and metabolic syndrome among people with comorbidity, have a better understanding of ways to overcome patient and practitioner barriers to address physical health and lifestyle factors, and have an improved understanding of the need for collaboration and techniques to facilitate coordinated care. But just before we get going, I wanted to do a really quick welcome poll, and just to see who who we have online tonight. So if you could just all take a second to tell us who you are, what your main working role is, that would be really great. And if you're in another role, maybe you could write that in the chat box and we can just say hello to you and you say hello back to us through your computer. So I'll just leave it open for another, maybe 10 seconds. We've got quite a broad range of people who are online tonight. Hello, everyone. Great. So thanks so much for doing that. And in terms of what we'll be covering in tonight's webinar, I'm going to start with a brief overview of what we know about comorbidity, followed by behavioural risk factors. And I'll then talk a bit about some of the patient and practitioner barriers to addressing physical health and other lifestyle factors. And I'll then finish up by talking about the importance of coordinated care. But I'd like to start by introducing you all to Tim. So Tim's a 38-year-old man who has a history of psychosis dating back to his teenage years. Although he has a number of admissions to inpatient psychiatric units in his early 20s, since that time he's been managed within community mental health services. But his recent lifestyle has been quite chaotic. He's moved house 5 times in the last 12 months, and so he's been under the care of several different community mental health services, and there's been no single clinician who's gotten to know him well. During his frequent moves, he's also been under the care of several different GPs. He presented to emergency following an argument with another resident in the hostel where he was staying, and his injuries were quite minor, but the doctor and nurse who assessed him noted that he had quite high blood pressure and he was overweight with a body mass index, or BMI, of 32. It was also noted that he had a severe cough, which Tim thought was because he smoked more than 40 cigarettes a day. When he was asked about his blood pressure, Tim told the he told the doctor that his GP prescribed him medication, but he was not taking it because it was too expensive, and he hadn't been attending any follow-up appointments with his GP. So this information was brought to the attention of the community mental health service who were caring for Tim, and they followed up with him and encouraged him to come in for a comprehensive physical assessment. Over many years, it was clear that Tim had been prescribed various antipsychotic medications and mood stabilizers, and it was obvious that he'd put on a lot of weight. Despite the long-term use of antipsychotics and his high BMI, he hadn't been tested for type 2 diabetes or had any routine blood tests. His glucose levels, liver function, thyroid function, or hemoglobin had also never been tested. So I'd just like you to try and keep these few brief facts that I've mentioned about Tim in your minds as we progress through the rest of the webinar tonight, and have a think about how we might need to address his behavioural risk factors, if at all, and how we might go about doing this if it's identified that we should. A few negatives in that sentence, sorry about that. Now, before doing that, we need to think about, or we need to consider Tim's presenting issues, and in doing so, think about them within the broader context of what we know about comorbidity. Before doing that, I wanted to clarify what I mean when I'm talking about comorbidity. So broadly defined, comorbidity refers to the co-occurrence, so either lifetime or current, of 2 or more disorders. And our focus here today is on the co-occurrence of alcohol or other drug, or AOD, and mental health disorders or conditions. And there are, of course, lots of other different types of comorbidity. We also know that comorbidity is common. Mental and substance use disorders are 2 of Australia's most common and burdensome health conditions. They affect around 1 in 5 Australian adults each year, and they frequently co-occur. It's estimated that around 1 in 3 Australians with a substance use disorder also have a mental health disorder, but this rate can be as high as about 75% among people who are seeking treatment. So in terms of the most common mental health conditions that we see to co-occur with substance use disorders, these are typically the same as those that we see in the general population, and they are anxiety and depression, post-traumatic stress disorder, and personality disorders. But we also see elevated rates of bipolar disorder, psychosis, attention deficit hyperactivity disorder, obsessive compulsive disorder, and eating disorders. And the fact that these disorders co-occur is problematic because once they're established, each serves to maintain and exacerbate the other. There are also a lot of people who experience symptoms of their disorders, but they don't necessarily meet the criteria for a diagnosis of disorder. So this means that a lot of people can still have their lives significantly disrupted by their symptoms of mental health disorders, but without meeting the diagnostic criteria, they tend to sort of fly under the radar of some services. So rather than thinking about mental health as the presence or the absence of disorder, it can be quite useful to think of the mental health conditions as if they were on a continuum, ranging from mild symptoms such as mild depression on one end to more severe disorders such as schizophrenia or psychotic or suicidal ideation, suicidal depression on the other end. The prevalence of mental health disorders can also vary between substances, but there's been little research conducted which compares the rates of mental health disorders across the different types of substance use disorders. So there's not a lot of information available which can guide health practitioners in this sense. Substance use among people with mental health disorders tends to mirror the general population trends in terms of availability and fashion, with the most commonly used substances in the general population being tobacco and alcohol, followed by smaller proportions who use illicit substances. But in general, few people who experience these conditions access treatment, so in part because they have difficulty accessing services and because of the stigma that they're often faced with when they do. So an estimated 1 in 10 people with a substance use disorder alone seek treatment. But when you have substance use, mood, and anxiety, this rate increases to around 70 to 80%, which indicates that mental health or the complexities that accompany comorbidity might be a driver into treatment. And even among those people who do manage to access treatment, there's often an incredibly lengthy delay between the time when they start to experience symptoms and when they eventually make treatment contact. So the evidence tells us that the median delay among people with alcohol use disorders who eventually make treatment contact in Australia is 18 years. And a large part of the problem in people being able to access treatment is that our clinical services, and particularly those in relation to comorbidity, have traditionally adopted a siloed approach where mental and substance use disorders are treated separately. And as a consequence, people can be bounced between mental health and AOD services with little continuity or coordination of care, and they can fall between the cracks in their healthcare system. So comorbidity is quite a big problem because not only do people with comorbidity experience their symptoms of mental health and substance use disorders, but they also have complex presentations, and these can complicate their treatment and recovery. And it's this last point here. Sorry, just a minute. Research has shown that people with mental and substance use disorders die an astonishing 20 to 30 years earlier than the general population and spend the last 10 years of life living with disabling chronic illnesses. And it's this that I wanted to focus on as we move forward, because the key points so far are that comorbidity is common and can complicate a person's treatment and recovery. Once comorbid conditions have been established, it's most likely the relationship between them is one of mutual influence. A number of barriers make it difficult for people with comorbidity to receive effective treatment, and people with comorbidity have shorter life expectancies than the general population and spend the last 10 years of life living with disabling chronic illnesses. So this last point here, looking at behavioural risk factors and metabolic syndrome among people with comorbidity, is really important, thinking about how we'll move forward in terms of behavioural risk factors and metabolic syndrome. So within this, I'll talk about some of the patient and practitioner barriers to addressing physical health and other lifestyle factors, as well as some of the strategies to overcome barriers. And before doing that, I wanted to ask another poll question, which is, compared to the general population, what do you think is the mortality rate of consumers of mental health services? So do you think it's around half, about the same, or more than double the rate of the general population? So I'll just leave that open for another 10 seconds or so. Just a few more votes are coming in. Great, thank you. So thanks so much for doing that. And I really wanted to ask you all that because I think it's so important to think about why we need to consider physical health among people with mental health and substance use problems. As we've talked about over the last few webinars, if you've joined us, and as I'll talk about a little later, people with both mental and substance use conditions often present to treatment with a range of other issues that need to be addressed throughout the course of treatment. So why should we be particularly concerned about their physical health? And first of all, we need to be concerned because consumers of mental health services have, as I think everybody who answered that poll identified, more than double the mortality rate of the general population, particularly due to cardiovascular disease or CVD. So risk factors for CVD are also prominent among people with AOD and mental health conditions. And these factors also increase the risk of metabolic syndrome. And I'll come back to this in a minute. So risk factors for CVD among people with comorbidity are mainly due to high rates of smoking, overweight and obesity, diabetes, poor diet, physical inactivity, high rates of alcohol consumption, and the use of some antipsychotic medications. So researchers really highlighted the need for interventions that focus on overall well-being, including reducing smoking, improving dietary habits, increasing physical activity, and improving sleep patterns. So from a health worker's perspective, remembering that physical and mental health are fundamentally linked and focusing on overall well-being by taking steps to manage clients' physical and mental health is likely to lead to improved outcomes. Metabolic syndrome is the presence of 3 or more of the risk factors that I have here on screen, and these are elevated waist circumference or central obesity, raised triglycerides, increased blood pressure, increased glucose, and lowered high-density lipoprotein cholesterol. 1/3 of Australians are currently diagnosed with metabolic syndrome, which this is directly affected by sleep, physical activity, and diet. So what we know from the research is that people with mental health disorders, so for example, schizophrenia, bipolar disorder, depression, post-traumatic stress disorder, and borderline personality disorder should be considered a high-risk group for metabolic syndrome and the associated morbidity and mortality, particularly those who are prescribed antipsychotics. So I have here another poll question, and I'd just like you all to think about what are the 4 primary risk factors that we need to consider among people with comorbidity, and you can choose as many as you like, up to 4 options, preferably, because we're looking for 4. So do you think that the big 4 primary risk factors are smoking, depression, poor diet, social isolation, physical inactivity, inadequate sleep, all of these or none of these? So I'll leave it open for another 10 seconds or so. Just a couple more coming in. Great, thank you. So quite a range actually of responses that have come in there. Oh, lost my mouse, okay. So the 4 primary behavioural risk factors that we should all be familiar with and that I'll be going through in more detail in the next few slides are smoking, poor diet, physical inactivity, and inadequate sleep. So I'll start first of all with smoking. Smoking rates among people who are attending AOD treatment are quite substantial, and they range between 74 to 98%. So compared to the general population, people with substance use and mental health conditions smoke substantially more cigarettes per day, and they're more likely to be nicotine dependent. So despite nicotine accounting for the highest rate of mortality among people with AOD and mental health conditions, the focus of treatment is really primarily centered on substances other than tobacco. The reluctance to address smoking by healthcare workers may be due in part to the belief that doing so can exacerbate other substance use and increase psychiatric symptoms and aggression, but this really isn't supported by the evidence that we have. Nicotine is also known to interact with the metabolism of some medications and drugs. So there can be changes in how some medications are metabolized, particularly clozapine and olanzapine, following the cessation of smoking or nicotine replacement therapy, or NRT. So if AOD clients are withdrawing from nicotine, they should be made aware of the potential for changes in metabolism and the increased absorption of caffeine. So for example, in coffee, tea, chocolate, and soft drinks. And these can lead to restlessness and lack of sleep. NRT can be used to minimize the physiological symptoms of nicotine withdrawal, and it's available in patches, gum, inhalers, lozenges, and microtabs. And it's not recommended without a clinical assessment or as a first line of treatment for clients who are pregnant or are likely to become pregnant, who are currently breastfeeding, who have significant cardiac or active vascular disease, or have nicotine sensitivities or allergies. So clinicians managing clients on NRT should regularly be monitoring clients' withdrawal and tailoring the NRT dose and addressing triggers, cravings, and stress through accompanying psychosocial interventions. Despite evidence which tells us that smoking can be ineffective or could be effectively addressed among clients of AOD and mental health services, there's been quite a lot of inconsistency with the way smoking interventions have been implemented. A greater number of AOD staff smoke in comparison to the general population, and they sometimes smoke with clients in order to promote a therapeutic relationship. Negative attitudes among treatment staff have also been acknowledged as potential barriers to effectively targeting nicotine dependence, with staff who smoke themselves being less likely to initiate smoking cessation among clients and then be less successful when they do. So secondly, I'm going to talk about diet. Clients of AOD treatment services tend to have poor dietary habits, and they often choose to eat nutrient-poor, energy-dense food, often to excess. So it's quite common for those who are accessing AOD treatment to report unhealthy eating patterns, weight gain, and obesity, which suggests that energy-dense diets are sometimes used to substitute AOD during recovery. What we know from the evidence suggests that programs that target the preparation of nutritional foods can promote lasting weight loss among people with mental health conditions, and healthcare workers can help by encouraging adherence to Australian dietary guidelines. So some strategies that can help promote healthy eating that clinicians might find useful for their clients include eating a variety of foods that are high in fibre and low in fats, eating 7 or more fruits and vegetables a day, drinking lots of water, making healthy food choices and eating regularly, and managing healthy eating patterns. So making sure that breakfast is eaten every day and that healthy eating patterns are maintained on weekends and weekdays. Workers might also find the spending structure that I have on screen here useful, and this was developed under the Food Sense program, to promote healthy eating on a limited budget, and it was designed to be used alongside the Australian Government Department of Health's healthy eating guidelines. So it's recommended that 60% of the food budget is allocated to foods from the Eat Most group and 10% to the Eat Least group. So I'm going to talk a bit about physical activity and exercise. So although physical and psychological benefits of physical exercise have been well established, it's estimated that a quarter of adults are inactive and few achieve the recommended 30 minutes of moderate intensity exercise most days. So insufficient physical activity accounts for about 9% of premature mortality worldwide, and an increasing amount of research has focused on the potential benefits of exercise in AOD and mental health treatment. Physical activity has been highlighted as a safe alternative behaviour, and it's naturally rewarding and engaging, and it has a lot of health benefits. It's been associated with improved health, improved depression and mood, reduced levels of anxiety, reduced effects of withdrawal, and it's considered to be safe when exercises have been individually tailored. So together these factors make physical activity an appealing adjunctive intervention that can assist with relapse prevention among those who are in treatment for their substance use. Physical activity has also been shown to be inversely related to smoking status. So non-smokers are typically more physically active than smokers. The number of cigarettes smoked and also nicotine dependence, and recent evidence suggests that exercise can be maybe an effective complementary intervention to smoking cessation strategies. It's been shown to improve cardiovascular, pulmonary and immune functioning, and this in turn can help with the prevention of chronic disease. Smoking cessation is also more successful for those who exercise during their attempts to quit, and exercise can help with the prevention of relapse. Physical activity can also help alleviate symptoms of smoking withdrawal, such as irritability, depression, restlessness, and stress. So we also know from the evidence that although people with substance use disorders may be interested in increasing their levels of physical activity, it's unclear how often those in treatment settings regularly engage in moderate to vigorous levels of exercise, with few treatment programs incorporating dedicated time for exercise. So particular social settings, activities, or times of the day associated with substance use can also become environmental cues, and these can then increase the risk of relapse. Instead of using substances when cravings or urges to use come about, exercising or being physically active can help reduce the likelihood of relapse. Exercise or regular exercise is often associated with other positive behaviours such as healthy diet and sleep patterns and overall feelings of well-being, vitality, high energy, and motivation to maintain healthy lifestyle practices. So I've talked a bit about the associations between exercise and improvements in substance use, depression, anxiety, and stress, and these all suggest that exercise is potentially a promising accompanying treatment for substance use. But despite this, the ideal dose, so the type of exercise, the duration, and also the intensity of exercise that's needed to maximize the effects of the potential health and psychological benefits is not yet known, and it's still the subject of a lot of research that's ongoing. But what we do know so far suggests that the ideal dose varies between people, and it depends a lot on individual preferences as well as the baseline levels of physical fitness. So there are 6 physical activity and sedentary behaviour guidelines for adults, which might be useful. So these are: any physical activity is better than none. If there is currently none, start with a small amount, gradually build this up to the recommended amount. Be active most days and preferably all days of the week. Accumulate 2.5 to 5 hours of moderate intensity physical activity, so that's being out of breath but can still say a few words, or 1.25 to 2.5 hours of vigorous intensity physical activity, which is being out of breath but and with difficulty talking, or having a combination of both each week. Incorporate muscle strengthening exercises each week, minimize the amount of time that's spent in prolonged sitting, and break up long periods of sitting as often as possible. Of course, I'm sure everybody watching practices all of these like I do. So despite the overwhelming evidence of poor physical health among people with mental health conditions, relatively few workers address the physical health of their clients as part of their practice. So this may be partly due to clinicians questioning whether health and wellness are achievable goals for people with mental health conditions due to perceived lack of motivation, lifestyle challenges, and also the side effects and complications of many medications. So for example, weight gain, glucose and lipid abnormalities, and also cardiac side effects. So although some research suggests that clients may prefer to make simultaneous behavioural changes, clinicians may not feel ready or may feel underprepared to manage the physical health of clients, particularly when standard screening tools and assessments are not addressing the importance of physical health screening. So a resource that might be useful is on screen here, and this is the Food and Activity Diary, and it can help clients and clinicians make links between food, levels of activity, and also mood. So I have the link on screen at the bottom of, I have the link to access this on screen there. There's also been some research that has looked at the exercise attitudes and behaviours of people who have been in treatment, and this has identified that although a lot of people are interested in being involved in physical activities as part of their recovery, there's been some reluctance due to perceived barriers, and these have included financial costs and lack of motivation. So some strategies that include self-monitoring, goal setting, contingency management, and relapse prevention planning might be useful. Devices that track physical activity like pedometers, heart rate monitors, and fitness trackers can also be used as motivational tools, but these haven't been tested as exercise interventions in substance use populations. So I wanted to put some links up to a few really good examples of behavioural changes from the fun theory. And this is an annual award financed by Volkswagen, which aims to encourage fun interventions or ideas with the end goal of behavioural change. So I would just like to show one short video now, but I won't show all of them. And you should be able to look at these examples after the webinar when these slides are changed into a PDF. And I really encourage you to do that because the examples on these slides are really fantastic examples of how people have been motivated to change their behaviour by thinking outside the box. So each of these videos, they're really short. They're only 1.5 to 2 minutes long. The first one here is the piano stairs, and it's an example of how visitors to a Swedish train station were motivated to increase their physical activity. And this was done in an underground Swedish train station where the staircase was transformed into an interactive piano keyboard to try to encourage more people to choose to take the stairs over the escalators. In the second example, a bottle bank was transformed into an arcade machine, and this was done to try to encourage more people to recycle. The third video down the bottom shows how obeying the speed limit was made fun, and this was done by entering people who were not speeding, as in road speeding, driving, into a lottery to win a pot of money that was made up of fines that were given to people who were speeding. And this initiative has actually been put into practice in Stockholm in Sweden. So I'll play the first video, and which I said it's quite short. It only goes for 1:40. If you can't hear any audio while it's playing, don't worry too much. I tested it before and it worked okay, but just in case, there's no words. You should be able to get the message just from the behavior change, and it's evident without the audio. So that's just one of 3 examples of behavior change and how thinking outside the box can motivate some people to want to change their behavior. So you can see a couple more examples on the Fun Theory website and also a few other places. And of course, I'm not suggesting that you make these particular changes or turn your office stairs into piano staircase, but maybe have a think about some different ways of approaching behavioral and lifestyle changes. So clients aren't necessarily thinking about them with, mentality. So moving on to sleep. Sleep problems can be experienced in many ways and range from difficulty falling asleep, maintaining sleep throughout the night, or waking too early or too often. So most people will experience some trouble falling or some trouble sleeping at some point in their lives, with less sleep associated with long work days, commuting times, increases in evening or night work, and also the overuse of television, computers, and the internet. Sleep disturbances have also been associated with the use of and withdrawal from substances, so in particular, alcohol, cannabis, tobacco, caffeine, and cocaine. Although some people report the use of substances to promote sleep, in general, the direction of this relationship isn't really well understood. So for example, it's not really clear whether sleep problems are an additional risk factor which contribute to a person's substance use, or whether the use of substances contribute to a person's sleep disturbances. So the quality and quantity, or the duration of sleep, has been linked to chronic disease, with insufficient sleep associated with higher body mass, weight gain, obesity, diabetes, CVD, and premature mortality. So recent research suggests that the ideal amount of sleep varies with age. For adults between 18 to 64 years, the recommended duration of sleep is between 7 and 9 hours. The increased risk of chronic diseases, obesity, diabetes, hypertension, and CVD is associated with both too little, so less than 6 hours, and also too much sleep, so more than 9 hours. Some healthy sleep habits which clinicians might find useful for their clients include maintaining a regular sleeping schedule. So on weekends and weekdays, going to bed around the same time each night, trying to wake up at the same time each morning. Ensure at least 7 hours of sleep. Don't go to bed unless tired. Get out of bed, if not asleep, within 20 minutes. Practice relaxing bedtime rituals. So for example, mindfulness, meditation, relaxation exercises. Only use the bed for sleep and sex. Ensure the bedroom is calm and relaxing, and maintain a cool, comfortable temperature. Limit the exposure to bright lights before bedtime. Don't eat large meals before bedtime, so if you're hungry, have a light, healthy snack. Exercise regularly. Avoid caffeine in the late afternoon and evening. Avoid alcohol before bedtime, and reduce fluid intake before bedtime. So far I've really mainly focused on the importance of addressing physical health among people with comorbidity. I just wanted to briefly mention, without going into detail, that it's also really important to think about assessing and managing comorbidity or AOD and mental health conditions among people who present to services with physical health problems, because comorbid conditions among these populations often go unrecognised as well. So in terms of what managing physical health means for healthcare workers, as a broad focus of a holistic approach is centred on delivering the right services to the right person at the right time, healthcare workers' role really include involving multiple services in a coordinated, client-centred approach. So this really means that healthcare workers' roles should be prepared to not only address the mental and physical well-being of their clients, but also involve and partner with other services that can provide complete, individualised care. So some key points to take from the patient and practitioner barriers to addressing physical health and other lifestyle factors are that some service providers are reluctant to address multiple health behaviours because of the belief that making too many lifestyle changes will undermine a person's recovery from AOD use. And although this is particularly evident in relation to smoking cessation, it's really not supported by the evidence. So some strategies to help or to assist healthcare workers overcome some of the barriers associated with these behavioural changes include helping clients minimise the physiological symptoms of nicotine withdrawal with NRT, and being mindful of the different doses, the potential for NRT to interact with the metabolism of different medications, and also the contraindications of use. Using the Australian Dietary Guidelines to help clients develop healthy eating patterns, or the food spending structure, and this links household budgets to food groups, the food and activity diary, and other devices that track physical activity, such as pedometers, heart rate monitors, fitness trackers as motivational tools, as well as healthy sleep habits. So finally, I wanted to touch on coordinated care. As I mentioned earlier in the webinar, and as a lot of you know, people with comorbidity often present to treatment with various issues that need to be addressed throughout the course of treatment. So for example, education and training, family situations, housing, legal issues, employment, and physical health. So we really highlight the importance of health services and workers developing links with a range of local services and then engaging them in clients' treatment where it's appropriate. So in practice, coordinated care should really involve the coordinated delivery of individual services across multiple sectors, when this is perceived as a seamless service system by clients, which results in overall improved client outcomes. So with Tim, as I mentioned before, we identified mental health, housing, and physical health. So the types of services that we would need to bring in would include housing, his psychologist, his psychiatrist, community mental health, and of course his GP. There are often times when clinicians refer clients to external workers or services, and as I mentioned earlier in the webinar, one of the biggest risks in this is the potential for clients to fall through the gaps and then disappear from treatment altogether. As a result of this, people can be bounced between mental health and AOD services with little continuity or continuation or coordination of care. So people with comorbidity often have difficulty navigating their way through available services. These can be quite difficult to access with multiple entry points and options of treatment pathways, agencies, and healthcare providers. So it's therefore really critical for care coordination and the referral process to focus on linking clients in with services as smoothly as possible. So the development of formal links between services regarding consultation, referral pathways, and collaboration can really help with this. Coordinated care actually has been found to increase the likelihood that clients will receive specialised assistance where it's needed, and it facilitates client engagement in treatment. And research has shown that coordinated care has been linked with improved treatment outcomes, with prolonged client retention, increased treatment satisfaction, improved quality of life, and increased use of community-based services. So in terms of health worker roles in coordinated care, this can involve the coordination, management, and delivery of appropriate services. And then the challenge in this is really in the active engagement of multiple services and service providers with a mixture of professional and non-professional support. And also working out whose responsibility is it to coordinate the care. So while primary healthcare workers are in ideal positions to coordinate care and incorporate services that best reflect their clients' individual needs to deliver the best quality care, they're often incredibly time poor. So just to give a summary of all of this information, AOD and other mental health disorders are common. People with comorbidity are often at increased risk of physical health problems and with higher mortality rates than the general population. Those with comorbidity are at particular risk of developing cardiovascular disease due to high rates of smoking, overweight and obesity, diabetes, poor diet, physical inactivity, high rates of alcohol consumption, and the use of some antipsychotic medications. So recent research has really highlighted the need for interventions that focus on overall well-being, including reducing smoking, improving dietary habits, increasing physical activity, and improving sleep patterns. And crucial to this approach is the inclusion of multiple services and multiple service providers who reflect the complex need of clients and are able to deliver the right care to the right person at the right time. So coming back to Tim, what happened to Tim? The community mental health nurse liaised with Tim's GP and organised several physical health assessments and also arranged for Tim arranged to meet Tim at his home on the day of his tests to ensure that he kept his appointments. The nurse was also able to meet Tim on the day of his GP appointment to discuss the results. So over the next few months, Tim's community mental health nurse coordinated the care between Tim and his GP and helped ensure that Tim remained in contact with his GP and attended his follow-up appointments. The nurse also encouraged him to attend an exercise class at his gym, and his GP made a referral to a dietitian who gave Tim some nutritional advice and developed a tailored eating plan. The GP worked out a smoking cessation program for Tim, part of which involved NRT. One central continuing need was for Tim to have assertive support and follow-up, including his notes being passed on if he moved again, and the acknowledgement that without this level of support, there was a real possibility that Tim would drift on and stop attending his appointments. So Tim's nurse also reminded him of his healthcare appointments via text message. So the key points to take from Tim's case study are, there is a need for healthcare workers to focus on physical health as a priority, bearing in mind the years of life lost in this population. Once the health needs of clients are recognised, holistic healthcare interventions such as physical activity, smoking cessation, healthy eating, and healthy sleep patterns can follow. And the importance of compliance with physical health medications such as blood pressure medications and diabetes medications, these should really also be emphasised. Many clients might also require more assertive follow-up, including long-term practical support. So for example, phone or text reminders or someone to go with the client to appointments. Communication between workers and mental health services and GPs is also essential. And I just wanted to add a final take-home message for today, just to summarise everything that we've covered, which is that given that clients with comorbidity often have a variety of other medical, family and social problems, it's really important to adopt a holistic approach that's based on treating the person and not their illness. I just wanted to thank everybody for having joined us for this webinar. If you're interested in viewing this or other webinar recordings, they can be viewed via the CREMS website, which Kath mentioned earlier, which is comorbidity.edu.au/training/webinars. And to complete the CPD assessment, which has been attached to this webinar, you just have to click on the link on this slide. And remember that I'll make these slides clickable at the end of this, just after I finish. And remember to submit your responses. And there'll be more webinar topics which will be covered through the CREMS webinar series. If you're interested in any of these, you can subscribe to the mailing list, which is also on this slide. But thank you.
Fabulous. And also feel free to email us with any suggestions you might have for future webinar topics that you might like to see. Thank you so much, Chris. That was great. And I guess, like you said, you really summed it up there, how important this topic is in relation to the principles of providing holistic care for people in treatment. And I loved your example of the outside the box, ways of thinking to try and, I guess, trick ourselves into doing something that's really good for us. We do have some questions for you as well, and if everyone, please feel free to submit any more questions or comments if you would like. Firstly, I just wanted to make a comment though as well, Chris, about you mentioning about the high rates of smoking in people who are accessing substance use and mental health treatments. And I think it's about it's upwards, I think, of 2/3 of people. But just to make the comment that, when we look at the population levels, we can see that Australia is really leading the world in terms of reducing smoking in the general population. But it's these kind of populations that I guess are hidden in that. And for people with severe mental illness in particular, like bipolar disorders, schizophrenia, severe major depression, that these rates actually haven't changed in the last decade, and that we really do need to find better ways and research better how do we address tobacco and nicotine, cigarette smoking in these kinds of populations. Sorry, enough of my ranting. So questions you have. Do you, like you mentioned those interventions for smoking that are available. Do you know of other interventions that are being trialled that are sort of more targeting those big risk factors more broadly?
That's a good question. Off the top of my head, I can't give you the names of any, but there are several interventions that are being trialled that target, the big four, or actually the big six, which include alcohol and sedentary behaviours. I think a number of these, I think, have been developed for online or app-based use, and they really focus on healthy lifestyles. So not just smoking, as you mentioned, but across the realm of what healthy lifestyles is. So addressing, the 4 or 6 behavioural changes.
Yeah, and I think as well there is some evidence to suggest that people might be more amenable to addressing these issues perhaps than their mental health or substance use if they're having issues. So it might also be a gateway into addressing those problems as well as people start to feel better and wanting to make other changes in their life as well.
Yeah.
And also you mentioned some of the barriers for, like, there's just been a note here made about that financial constraints can be a real barrier, I guess, to people participating in exercise programs.
Yeah, absolutely. Yeah, totally. Going to the gym is really expensive. Even playing a team sport, you have to pay to do that. I looked at roller derby, that's really expensive too, apparently. But there are lots of things that don't cost money that can be enjoyable. Just going for a swim at the beach, walking your dog, just walking yourself or your friend, going for a bike ride. There are lots of alternatives that don't actually cost money that can be enjoyable too.
Yeah, and I guess that kind of fits as well with what you were talking about in the last seminar on managing and treating, where you were talking about pleasant event scheduling and how important that can be for people managing their symptoms, and like you say, they could be enjoyable things that benefit your physical health as well as potentially improving your substance use and mental health too, because you also talked about the fact that physical activity, there's some increasing evidence that can also have an impact on substance use and mental health. Is that right?
Yes. Yes.
Cool. And another question we have here is whether or not you're a clinician or a healthcare provider in any way, or a consumer or carer or anyone in the community, if you're concerned about someone having metabolic syndrome, what should they do?
Yeah, I think that's, really important consideration. And I think that if you are a clinician, who's not a GP, I think probably the first thing is to try to liaise with the person's GP and try to organise some physical health assessments and get them done as soon as possible, because although metabolic syndrome is something that can be treated and managed, of course it's something that you want to get onto quickly, so early intervention is really key. And the same, I guess, if you're not a clinician, try to liaise with the GP, get physical assessments, early intervention.
Yeah, and it's also constantly just thinking about constantly monitoring as well, that particularly for those people that you mentioned who might be at particularly high risk, like people who are taking antipsychotic medications, to make sure to be able to get on top of it, because I guess that often some of those things that come with the medications, people weigh up whether or not should I be on my medication and have all of these other negative outcomes that are really going to affect my health.
Yeah, and it's something that it's not necessarily a short-term fix. There's no, it's something that's going to have to be managed over the long term, but it is manageable.
Yep. Great. And also just a comment coming through about with the exercise, about morning exercise being useful for people to improve their mood to good effect.
Yeah.
That's all the questions that we have for you today, Chris. But I don't know, are there any other comments you wanted to make before we finished up, or are there any other last-minute questions or comments that anyone wanted to send through?
No, just that if there are any other questions or thoughts that occur to anyone percolating over the next few days, feel free to send them to me. My email address is on that last slide there. Get in touch.
Great, thanks. And just another comment coming through, which is really helpful, about some mental health facilities having actual metabolic clinics that GPs can refer to as well, which is really helpful. Thank you. Awesome. Well, thank you, Chris, not just for this seminar, but for the 4, all up that you've delivered. They've been really good, really comprehensive, fit a lot of information into a very short amount of time. And thank you, everyone, for joining us for them. And we hope they've been enjoyable and hope to see you at others in the future.
Thank you.
Thanks.